If you try to remember what you still know, as a 5-year-old, all your memories are associated with sometimes negative memories. We have much more memory for negative things. And humor sometimes gets better to the core of a hidden truth and the spirit of a cause. This is a Scottish study where they looked at 1/3 of the population, 1.7 million people, and you see that half the population was healthy, did not have any disorder, and half of the population had one or more disorders. 19% of the population had a single condition, and 23% of the population had 2 or more disorders. Now let me emphasize that although it's dependent on age, if you look at the Children's Hospital, University Children's Hospital in Zurich, half the children are severely multimorbid. And I might say that, need to go back. I might also say that these 50% that consider themselves healthy so far never had an MRI that found some node somewhere in the kidney or in the liver or in the lung. How do people that have an MRI respond to an incidental finding that where the doctor says, oh, we need a control in half a year, might be cancer? How do they respond? That's a new problem. 90% of patients admitted to the internal medicine ward in the hospital where I worked were significantly multimorbid. But now I have a grotesque thought. The grandma may be multimorbid, but she's still healthy. And let me show you with that video sequence. It needs the sound. The sound is essential. I'm sorry. Can we get the sound to...
We tried yesterday, it was working.
Yes.
Can you please play it again?
No, I need to get back. Sorry. Now that lady is obviously multimorbid. She walks slowly. She has certainly multiple problems. But at the same time, she defends herself. She says no. She has a resilience, a spine where she says, no, that's not going to happen. And why did you laugh? Because you made fundamental attribution errors. Initially, you thought the video is about skateboarding. And then you looked around and you made the fundamental attribution, oh, that poor lady, she will succumb to problems. And then you were wrong. She defends herself. And that makes you laugh. So we need to be careful when we talk with patients to not make fundamental attribution errors. Now about disease interactions. First, definitions of multimorbidity, and then disease interactions. And I'm not going to go into the text, just read. Only chronic conditions. If you work in emergency care, I was also responsible for the emergency ward of the University Hospital Zurich. That doesn't make sense. Somebody has muscles dissolving, at the same time heart failure, at the same time we need to get fluid, a lot of fluid, but we are not allowed because of the heart. Doesn't make sense, acute problems. Chronic or acute, diseases, medical conditions. Hypertension, for example, is a condition. It's not a disease. Then there are diseases or illness. Illness is the perception of the patient. Disease is what we say, our perception. Now, the most relevant diagnosis I find is this one in the MESH. That's the National Library of Medicine. The MESH term introduced 2018, also based on research that we did. The complex interactions of several coexisting diseases. It's not just I have some skin problem here and an eye problem. In the previous definitions, that would have been considered multimorbidity, but that's not multimorbidity. It's colliding diagnosis where the management for one disease collides with the management of the other disease. For one disease, you should give fluid a lot. For the other disease, you are not allowed to give fluid. You get into a dilemma situation. Now I make you calculate. This is one condition. This is a second condition. And it's a problem because they collide. The management for one condition collides with the management of the other condition. Please count the lines. Collision, 1 line. 3 diseases, 3 lines, 1, 3. 6 lines, 10 lines, 15 lines. And you see that's a supralinear function. The complexity increases. Now in randomized studies, we reduce the complexity by randomizing patients to one thing, to one arm and to another arm. We therefore eliminate complexity. But reality is complexity. For example, if you look at the average human, we make about 15,000 to 30,000 decisions a day. What do I wear? Should I now do that now? Should I take the, etc. A lot. We ignore complexity. But the reality that we have clinically is complexity. I will show you this patient. That's a real patient that was admitted for heart failure, for hypertensive heart disease, and very high blood pressure readings, and he has a shortness of breath. When we took his blood, his NT-proBNP, that's a sign of heart failure, was very high. So he has heart failure. And then we did a chest X-ray, and he had pleural effusions, and we took fluid from the pleural effusions, and it turns out he has cancer cells in the pleural effusion. He has also a lung disease, COPD. He's a long-term smoker. What did we forget? Depression and anxiety. And own studies at the University Hospital Zurich in 200,000 inpatients during 10 years showed that depression does not appear in the list of diagnosis. It's a blind spot. Anxiety does not appear. And there may be other blind spots. For example, the book that René mentioned, I'm the fourth editor, it was founded 100 years ago. Lung embolisms, we may have forgotten that, we need lists to help us. And also Ehlers-Lambert syndrome, that's a paraneoplastic syndrome occurring in up to 10% of these patients. We may have forgotten that. Blind spots, they are frequent, prevalent, overlooked. Not so rare, overlooked. Now that's an own study published last year in the European journal, European Heart Journal. We looked at guidelines and we scanned about 2,000 papers, but ultimately we selected 65 cardiovascular guidelines and we looked how depression is handled. And you see that it's a broad selection: cardiovascular disease, heart failure, coronary artery disease, stroke, aortic disease, and we showed that only 3%, that means 2 of the guidelines about stroke, gave specific information how to screen for depression and how to potentially handle it. That means we are essentially blind. And let me get to an ingenious Swiss artist, Ursus Wehrli, because he was really upset by the mess of art, and so he introduced order into it. That's how we are organized in hospitals. Here is cardiology, here is psychiatry, here is internal medicine, here is neurology. They are not mixed systems. And the systems are set up for the training of doctors, but not for the handling of real patient situations. And it's even in architecture, it's true, the psychiatry hospital here is 3 kilometers away. That's odd. What could we do? The American College of Physicians in 2006 generated a paper. It's outdated, but the fundamental principles are not outdated. And they asked for comprehensive, coordinated, continuous care, CCCC. Comprehensive, coordinated, continuous care. So this is a picture from Ratatouille. We do have comprehensive care. What do you see? You see that groups may not work, may not collaborate well. For example, in a kitchen, they need to collaborate well. You also see that it's a power question. A group, the question is also about power. Who is the most powerful? That, for example, is an important thing in, I guess, spiritual care, because you realize as a human being, you are not the most powerful. Then it's also a gender problem sometimes, because these positions in Switzerland become more and more taken by women. So how do we do that? And surgeons, orthopedic surgeons, are usually men. The hospital I'm working in, they are very nice, so please. Are we well organized as interdisciplinary teams at operational and systemic levels? That was also a discussion concerning spiritual care. And this is an interesting thing. This is, for example, this picture is a non-collaborative, non-zero-sum game, and I would ask you to look that up. That's game theory. There is 0 games, but medicine never is, and there is non-zero games. For example, game theory is about interacting with somebody else where you don't know what he or she thinks. Two persons interact with each other, but each one does not know what he or she thinks or misunderstands what he or she says. So collaboration is defining things together, finding words. How could AI help healthcare? It could support decision making, flag problems that I outlined, ask, couldn't it, in my view, patients with cancer, heart failure, shortness of breath, that's very near to personality. Shortness of breath is very near to personality. They are extremely likely to be scared. Could we strengthen safety architecture, care navigation agents, etc.? And reduce administrative work, because we have now a crisis of senselessness in medical care, because we have to do all the administration. We have a crisis of senselessness. For example, that's a Norwegian study. Hjell and colleagues looked at essentially AI, how they correlate with screening for depression, PHQ-9, GAD-7, anxiety, and PSWQ-8, which is worry warts, somebody who worries all the time. Does AI better identify depression because it has more soul and because it realizes that patient may be depressive? Are we that bad that we don't realize what shortness of breath, heart failure, and cancer means to the patient? And let me give you an example now. I'm playing something. I'm asking a patient, how are you? And she says, well. Now the same question, how are you? Well, it's the same answer. In a large language model used by Hjell, that would be the same answer. When we are in daily practice, everybody realizes it's not the same answer. And perhaps in future, complex analytics, including pitch, analytics of mimics and moments, and even entropy, this elderly lady, of movement, will realize. For example, Google knows whether you are demented or not. Google knows whether you are demented or not, because in dementia, entropy of movement in your usual environment increases because you don't remember where you put things. So for Google, I'm kind of, okay, now. Now, this is human intelligence, and you obviously realize that guy interpreted something wrong. So the question is always, is the database well curated? Concerning multimorbidity, it can't be well curated because we have no data. Again, concerning multimorbidity, it can't be well curated because we don't have the data. So the current evidence, that's a picture, Steinberg, Union Square, New York. You see it's still a mess. So I'm taking up a few ideas. Dialogue is a fundamental principle in all religions. In Judaism, in the Old Testament, dialogue is a fundamental principle. God and humans connect across hierarchies. Actually, Abraham discusses and contradicts, defends, says, you can't do that, and others do that too, and humans connect. And in antiquity, an analytical concept was developed, which is called chavruta. That's an Aramaic word meaning companionship. And it's a principle where two persons discuss a text and intentionally take different perspectives. They say, for example, because of Shabbat, the cow is not allowed to work. Therefore, you're not allowed to take the milk away. The other one says, no, you need to milk the cow because you're not allowed to make an animal suffer. You need to take the milk. And then they discuss the principle and they will come to a way of going through the issue. And in traditional rabbinical schools, in yeshivot, that's the principle of learning. And even if you are not, if you don't think so, you are always saying the precise opposite in order to find a common way. It's a principle way. And let's look at some researchers, Jewish researchers. Einstein, matter is energy and matter. It's a chavruta between two things. It's the same, but different. You measure it differently, but it's the same. Of Freud, conscious and unconscious are distinct yet interacting forms of human existence. Dreams penetrate from one concept to the other. And perhaps there are also third dimensions that we can't measure with our human instruments yet, or will never be able to measure. They may be present, and some people may sense them better than others. Dreams give spiritual perspectives during transitions. Jacob's dream, Magia Hashemayma, Sulam, Mutzav Arza Vayachalom. He places the ladder on the earth and penetrates to another dimension, gets a new name, by the way, after that. In Talmud Brachot, that's interpretatory detailing work. That's an Aramaic sentence, Chalma de lo mufsha ke igrata de lo makri. A dream that is uninterpreted is like unread letters. Freud. Clinical analogy, blind spots such as fear, depression, suffering, despair, spiritual distress, and the subconscious can be unread letters if we ignore them. Here Chagall, the Songe de Jacob, giving that an expression. Blue, indigo, is the color of, to some extent, spirituality in Chagall's work. So that was work, and we realized that we have sensory systems that we neglect in comparison to animals, such as smell, sound, vision, etc. in our work. We are very semantic, verbally disciplined. So last things, lament is allowed. People are allowed to lament. Psalms, Job, Lamentations. One should not suppress verbalization, giving words a language to suffering. Patients may not be able to express it depending on their character, or may not allow themselves to express it to you, so we need to open doors, open the ladder. Then no one rescues himself alone. Talmud Brachot, that's one of the first tractates. Ein chavush matir atzmo mibei beit asurim. No one, that's Hebrew. No one is allowed to nobody can free himself from a prison. And our patients are very often in a prison of worry, of anxiety, and spiritual need. And kindness, that's also a Jewish and Christian and Muslim and so on principle. Kindness is a pillar of the world. And for example, in the Mishnah, Pirkei Avot, that's the second sentence of a very fundamental work that was codified about between the year 100 and 200 and before. But this is a saying by Rabbi Shimon HaTzadik, who lived about 400 before Christ. The world is on three pillars, and one of the pillars is loving kindness. And kindness, and there are studies, reduces fear, anxiety, depression, despair. That's evidence-based. And kindness is not sentimentality. It reduces uncertainty. Fear invites the patient's narrative and reveals hidden priorities. It generates trust. And now it's not the same like friendliness. Kindness is something different. And actually, German does not have a word for it. And not all languages have a word for it. Somebody told me that Hungarian has a word for it. Where is, yeah. And so, every language has a way to describe it. Kindness is more doing something unexpected, something beyond what a patient has expected. For example, a nurse saying, I can't deal with that now, I need to get my child, but can I come back to you with my child after my, much later, and so on, things like that. And if we try to look at memory, where I began, kindness is also very much something which raises emotions and for which we have a memory. And I will show you something. That's a citation from the book of Yeshayahu. Oops, doesn't work. Anyways, it's not so important. That would have been a film sequence where three musicians play in a hospital to raise the spirit of the patients. So back to disease-disease interactions, two perspectives and the bridge. That's three issues: perspective 1, perspective 2, and the bridge, mathematically. The text, or rather the narrative, is the patient's lived situation. For example, a disease-disease interaction. Because of the heart, you are not allowed to give any fluid. Because of the kidney, you need to give lots of fluid. What do you do now? How do we deal with it? Do we have time slots to discuss this and explain it? So we need clinical chavrutas, physicians, patients, families, specialists, nurses, and spiritual care to find the best potential solution together. Decisions that are medically, holistically, and personally sound and meaningful for patients, caregivers, family, friends, and the healthcare professionals. And I think we need to give room for chavruta in a metaphorical sense to discuss these issues alive, around the clock, at 2 o'clock in the morning, on a Saturday, and so on, at any given moment. I'm coming from a background with a round-the-clock service. So closing the circle, the last slides, chavruta, two people confirmed the text, a narrative, a question, three truths. Chavruta in general and for DDI, collaborative non-zero-sum game. That means if we do chavruta, that's an economic principle. Chavruta in game theory, the collaborative non-zero-sum game is the most successful game in game theory. So always when you look at an issue, do they apply do they apply collaborative, zero-sum games. If you, for example, look at a group doing research, which I did, looking how do they collaborate, do they accept the different roles, etc. Chavuta for DDI, complex patients managed by structured dialogue amongst disciplines. In tumor, those are the tumor boards, but there's much more variability, so you can't do a board for everything. You need to be flexible and gather around the patient if it's not a structured problem. And spiritual care, what does it mean to the patient, is caregivers and healthcare professionals. We need to look much more at healthcare professionals because they have anxieties too, because they have depressions too, because they have needs, spiritual needs, and others too. So my summary, take-home message is multimorbidity is the norm in healthcare. Single disease logic creates fragmentation, risk, and burden, and a non-collaborative non-zero game. Complexity grows through interactions, disease, drug disease, mental health, social context, and spiritual distress and resources. Advanced medical home, a term framed by the American College of Physicians, gives structure, patient-centered, physician-led, team-based, comprehensive, coordinated, and continuous. AI can support detection by interaction checks, navigation, and workload reduction, but only with curated data. We need to be careful about bad actors. We need to look at the data structure, and it's also a legal framework. So there is no, and that's a religious remark, there is no place in the world without law. There is no place in the world without law. And that in AI is not yet the case. And spirituality, kindness, and resilience matter when they are respectful, patient-centered dimensions of care. And the holistic medical perspective is not less scientific, it's science held in relationship and responsibility. And the word responsibility, Verantwortlichkeit in German, is a wonderful word. Responsibility, able. Being able to respond. We need to train that specific to the situation. That's it.